Good morning, people. We are really excited today to have Dr. Brendan Smyth, all the way from Sydney, Australia, where it is 10 p.m., presenting to us on his research on symptom management in kidney failure. Dr. Smyth is a physician, a nephrologist, and a PhD scientist at the St. George Hospital and the University of Sydney in Australia. And his PhD really focuses on what he's going to talk about on improving randomized clinical trial evidence in dialysis and specifically around symptoms in patients with kidney failure. And I won't talk about exactly what he's doing because he will be talking about that in his talk today. Welcome, Brendan.
Okay, yeah, thanks very much. And hi, everybody. Thank you for having me. It's great to be able to talk about a subject that I find quite interesting. I've mixed in, I think, obviously some of my own research, but then what I thought might be of interest to you guys is a bit of an update for symptom management. I know that a little bit of reading that I did that I think your network does have a focus on kidney supportive care and but you know, so hopefully this is still somewhat new to many of you. So let's get started. There we go. So some disclosures first off. And then look, just to set the scene, I think we all know this, but to kind of highlight it and then know that it's there in the background of everything that we say going forward. The patients we deal with kidney failure, particularly those who are older, have a high symptom burden. Yeah, this is data from our own unit. And we are looking here at a cohort of patients either on dialysis or managed on a conservative pathway and patients aged 65 or over. And you can see that the burden of fatigue is almost universal. Patients, a majority of patients have difficulty sleeping, itch, drowsiness, poor mobility, and pain. This graph is a little complex in that we're looking at, for each domain, 4 different aspects of it. We're looking at dialysis patients when they commence dialysis and 12 months later, and conservatively managed patients when they chose the conservative pathway, made that decision, and then 12 months beyond that. And I mean, the sad thing is that you really can't see much change. If anything, the dialysis patients get a little worse with time. So we've got work to do. In this talk, I'll cover some new areas in this symptom management space. So firstly, just some definitions that have been crystallized last year. And then this whole idea of routine symptom screening, because we're going to get a lot of data on that in the next couple of years. We'll look at current symptom practice, and I'll be taking some of my own work to, I think, talk a little about what we say we do and then what we actually do. And I think there are 3 important randomized trials that have relevance to symptom management in the past 12 months. And then we'll close out with an area that's of particular research interest to me, which is cannabinoids. So firstly, just some definitions. So last year, an ISM working group led by Sarah Davison, who I'm sure you guys know, set out to define kidney supportive care and conservative kidney management. And these are concepts that have been floating around, for a very long time, but various labels have been applied, and particularly the idea of conservative kidney management has often been talked about as, non-dialysis care or, treatment without dialysis. But the terminology, I think, has evolved in the right direction to remove some of that sense of withholding the treatment. So kidney supportive care is now defined as an approach that aims to improve the quality of life for people with kidney failure and to improve it, that's any aspect of their life, whether that's directly or indirectly related to their kidney disease. At the bottom there, it says it applies to all people with advanced chronic kidney disease. So this is not just about old dialysis patients. This applies even to transplant patients who we know, although they have a lower symptom burden, they still certainly have persistent symptoms. Conservative kidney management, or CKM, is care for people with kidney failure that focuses predominantly on quality of life. because for a number of reasons, these patients are not receiving kidney replacement therapy. Now, the other aspect of this working group's paper was to, I think, quite clearly distinguish between whether patients are choosing conservative kidney management in the context that we're used to in a high-income country, where transplant and dialysis are an option, but where the decision to pursue conservative kidney management is made, in conjunction between the clinicians and the patient. And there was, I know, a real push from people in low and middle income countries to ensure that the ISN really recognizes that there's a huge number of people globally who receive, or should be receiving, conservative kidney management, but are doing so because kidney replacement therapy is simply not available. And so the terminology selected was choice restricted CKM for that scenario. And I think that's another reason why it is important that we improve the evidence base for care of people with symptoms of kidney failure, so that those who don't have access to dialysis can at least have some, we may be more, it may be reasonably cheap and easy to provide good conservative kidney management. So we'll move on now and talk about routine symptom screening. So there's 3 interesting trials underway at the moment. Now, I'm not sure whether you guys are actually involved in empathy. I think it's led by Mike Walsh. And so this is the Canadian contribution to this, I think, really important conundrum of, do we actually invest substantially in routinely asking all of our, particularly dialysis patients, about their symptoms? It generates, it's work for the nursing staff, it's somewhat of a burden for the patients, and it generates additional work for us as the clinicians. And what difference does it actually make? The approach that the empathy team are taking is to look at a disease-specific patient-reported outcome measure, and that's either the ESAS renal or IPOS, which I suspect you guys are familiar with both. They're both just fairly straightforward symptom questionnaires. Comparing that to a generic health-related quality of life questionnaire, the EQ5D, versus an approach of using both in conjunction or just usual care, without routine screening. Now, of course, it may be that these tools are used on an ad hoc basis to assess particular patients. So the duration of this study is 12 months. The clinicians receive treatment guides, which can help direct what they actually do when they come across symptomatic patients. And of course, the patient-reported outcome measures are placed in the patient record. The primary outcome is an interesting one of the patient's sort of satisfaction with the patient-provider communication. And I'm sure they'll look at a range of important secondary outcomes, but that will provide an interesting window into how this whole process is perceived. So in Australia, down under, our approach is, it's similar. We're asking a very similar question in a slightly different way. We've got the Smyth study led by Rachel Morton, and that's a registry embedded into the binational Australian-New Zealand dialysis registry. Dialysis units are given a tablet, and that's passed around in the intervention arm. That's passed around every 3 months, and patients fill out their symptom questionnaire. There's an automated process where that goes via the registry, via ANS data, and then sent back, so that if patients score highly on one or more domains, the primary physician and the primary care nurse who are looking after them receive an alert, which is also accompanied by treatment guides. We're looking in Swift at health-related quality of life, so EQ5D. And then the Yanks are having a go as well. So Laura Denver's group is currently running the START HD trial, randomizing 30 units, I think in a stepped wedge design, using a bespoke symptom survey. I couldn't quite work out, it sounds like one they've developed themselves, but sounds very similar to ESAS renal and IPOS. Like Swift, they're automating alerts to the treating clinicians, also providing treatment guides, and their primary outcome seems to be symptom severity. So I think in the next few years, we'll have fantastic insight into how what we're doing helps. I mean, and I think we all assume that it does, and hopefully we'll be able to learn how to make it a little better. What strikes me too with these efforts is that each of these studies is providing clinicians with guidance on symptom treatment strategies. And the whole underlying rationale is that in identifying symptoms, you then apply effective treatments to improve outcomes. Well, I know Mike Walsh's study is looking at patient-provider communication, so it's not quite directly looking at the quality of life and symptoms, but we are assuming that what we do helps. But if we step back, I think we're still in a space where there's quite a lot of small studies, but not a lot of high quality evidence to guide what we do in symptom management. And we don't yet have the sort of evidence-based rated consensus guidelines that you get in other areas of kidney medicine. And I think that reflects just the state of the evidence for most symptoms that we come across. So with this in mind too, I wanted to have a look at what people are actually doing. And some colleagues from New Zealand and the UK, we got together and surveyed a whole range of units in these 3 countries. And I'll start with the data that we got back on pruritus. So we surveyed 104 kidney units in the 3 countries, and we asked a respondent from that unit to tell us what the usual practice was at that unit and whether they used a particular agent first or second line, or for refractory symptoms only, or it was rarely or never used. And obviously we know that individuals within a unit might do different things, but it still gives us some window into what might be going on in various units in 3 countries. I mean, this is a complex slide, and I think that's kind of part of the problem, is that you've got, we asked about something like 20 different drugs. We sort of went back to the Cochrane review, which lists huge numbers of random things that people have been using at various times for uremic pruritus. And we asked about all of those, and then got an additional set, you can see that tail there on the right, of free text responses that gave us over 30 different individual treatments. Now, the common things like gabapentin and pregabalin are what you would expect, and that there is reasonable evidence that those things work. But you've got this broad range of other things that are based often on fairly meager or very little evidence. There's also a lot of variability between countries. And I don't think all of that reflects availability or simply logistical or background reasons. I think prescribing cultures develop in different countries, and that implies, I think, that development occurs in an absence of evidence. And a great example is evening primrose oil, which I don't know if anyone in Canada uses, but it's quite widely used in Australia. So it's an oral supplement from the evening primrose plant, I guess. And it's quite high in gamma-linoleic acid, which shifts, I always forget exactly how, but it gets involved in the prostaglandin pathway. And so the idea is that it actually influences inflammation in the skin, which may play a role in uremic pruritus. And so that's really quite widely used as a first or second line agent in Australia. But I mean, even our UK colleagues were like, well, you guys are crazy. And I mean, I can say anecdotally it works, but there's no RC text. We also looked at insomnia, pain, cramps, and restless legs. And by the time we moved on to these symptoms and analyzed them, I've come across this different way of presenting it, which I find quite interesting, but bear with me. So what I've got here is each of these bars represents 100% of the responses. And you start at the left-hand side of the bar for the dark blue, which is the proportion of people who are responding that they use that first line, versus the red at the right-hand side. And that's the proportion saying they never use it. And then you've got grades in between. And if there's a consensus, then the bar is going to be to the left or the right. So if we look at restless leg syndrome at the bottom half of this screen, you can see gabapentinoids and dopamine agonists. It's their first or second line at most units, and that's what you'd expect, because this is one of those areas where there is some pretty reasonable evidence. Conversely, vitamin C, vitamin E, not a lot of evidence, and so no one's using them. But sleep is a good example of, we've got 5 different agents here, and the bars are in the middle. I mean, the group, we're split between people who just never use these things, given the first line, and everything in between. And that can actually be quantified numerically. There's a normalized generalized variance, which it's sort of a normalized way of looking at the probability of one respondent having a different answer to another. And so you can say numerically that the variation with insomnia is very high, which again just speaks to that lack of evidence. You see different patterns with different classes or different domains of symptoms. So in pain, and like we sort of said non-neuropathic pain, and that ended up being essentially use of opioids, there's also quite a lot of variability. I mean, most of us are pretty comfortable with oxycodone. There's not a lot of morphine use, but it is still striking that there are still, people who quite happily use morphine, whereas the teaching that I've always had is always to avoid it. In Australia, the teaching is very much to use hydromorphone as a preference in kidney failure, but that's clearly not at all universal. Some consistency in neuropathic pain, and sort of less so with cramps as well. Which then gets to the question of, well, what evidence do we have? And in the past 12 months, I think 3 studies have given us a little bit of insight. But first, I'll start with CONVINCE, which I'm sure most of you know, a fairly landmark trial in HDF. And the study recruited over 1,000 participants in 8 European countries, randomizing them to hemodiafiltration versus standard high flux hemodialysis, and followed them up for a median of 30 months. And obviously the study is designed to look at mortality. They showed a mortality benefit, but they also assess quality of life using the PROMIS 29 symptom sort of structure. They added a couple of things to that to look at fatigue and a few other bits and pieces. And so we'll look over the next few slides at the results they've presented in one of their secondary papers. And so you'll see a series of these graphs where the quality of life, the symptom score or quality of life score is, the red is for hemodialysis and the blue is for the HDF. The first thing to step back and say, I think, is unfortunately the symptoms are getting worse as patients progress. So it's not that they're stable, they're deteriorating, sadly. But you can also see that for all of these categories, for all of these symptoms or sort of domains of symptoms, hemodiafiltration appears a little better. The authors used an omnibus test, so they actually looked at 8 symptoms, and in addition to fatigue, sleep, anxiety, and depression, they also looked at physical and cognitive function, pain interference, and social participation. And across all of those 8 collectively, there was a strong, significant signal for HDF being better overall. Within that, they also went and did some secondary testing and found significant improvements with physical and particularly cognitive function, which was interesting. When you take summaries of these measures, you can look at physical and mental health sort of separately and disaggregate them, and both seem to show improvement, with the physical one being statistically significant. Now, these differences are modest, but it's still very much worthwhile. And I don't know what the HDF take up is, obviously in your part of the world, but it's still patchy in Australia. There are many units some units that just use it religiously and some that really don't. So yeah, obviously I hope that will change and HDF uptake will increase. A couple of other high quality RCTs. So Raj Malhotra and Mark Unruh produced Sleep HD, published in Annals of Internal Medicine last year, and they looked at insomnia. And so when we started this talk, difficulty sleeping was after fatigue, the second most prevalent symptom. And we know that many of the drugs that we've looked at, like benzodiazepines and sedative antihistamines, they have a reasonably high risk of side effects. So we sort of need good treatments for sleep. And so their group looked at cognitive behavioral therapy and a reasonably intensive schedule of CBT, so 6 30-minute Zoom calls, compared with a sedative antidepressant called trazodone or placebo. They recruited patients with poor sleep, defined by the Insomnia Severity Index, from 26 dialysis units and got over 120 participants randomized to this 3-arm parallel group trial. But unfortunately, the trial was negative, and quite obviously negative without even a trend in one direction or the other. Their primary outcome was at 7 weeks, and there was no difference between CBT, placebo, or trazodone. They looked at the number of secondary outcomes, of course, and really didn't find much benefit at all, sadly. So what leads us to another trial that has utilized CBD. So Laura Denver's group has led the HOPE trial, looking at CBT in the form of pain, sorry, that should say coping rather than scoping, pain coping skills training to reduce the impact of pain on or interference with daily function, and comparing that to usual care. And I mean, as you know, there's been real issues, particularly in the US, but more broadly with high levels of opiate use and dependence. And we know that pain's a real problem in our patient population as well. So this study randomized participants to 45 to 50-minute CBT sessions weekly, and that was conducted by telehealth, video, or conference. And then they backed this up with a 12-week, so they had 12 weeks of this weekly sessions, and then 12 further weeks of, now I have to be honest and say I'd never quite understood exactly what this second part is, but automated interactive voice response sessions. And I have looked at their protocol paper as well, still couldn't quite work it out, but it sounds like you call up and speak to an automated voice somehow that gives you some encouragement. But it's a validated technique, and obviously designed to supplement the CBT that's been delivered in the first 3 months of the program. They recruited hemodialysis patients from 100 units, and over 600 patients were randomized. And they did find some improvements in pain interference. They looked at the brief pain inventory, and their primary outcome was at 12 weeks, and there was a 0.5 point reduction in or difference between placebo and the CBT. The minimally clinically important difference on this scale is about 1. And so they also looked at the odds of participants having at least a 1 point improvement in their pain score. And the treatment group was much more likely to have that with an odds ratio of 1.79. There were also benefits across a range of quality of life and symptoms, or particularly quality of life, I should say, that one would associate with chronic pain. So the pain catastrophizing scale improved, the single item quality of life. So I think that's a visual, a VAS score where you just sort of indicate 0 to 100. That improved, as well as patient health questionnaire for depression and anxiety, the generalized anxiety score. So you're seeing some, I mean, these changes are not huge, but they're reasonably broad-based, which I think is promising in that we can show some improvement in pain without drugs. Although while the intervention can be delivered by telehealth, it's still reasonably intensive. They didn't seem to report any impact on opioid use, so I hope that'll come out in subsequent papers, as it might be interesting. Now, as a footnote to this, 15% of the patients in the HOPE trial were already using cannabis. Now, they don't say whether that's for pain. It may not be, might just be for shits and giggles, as we say down here. But for many patients, it may be as an attempt to treat their symptoms. which leads nicely into whether there is a role for cannabinoids in the management of symptoms. And I'd be interested in discussion to know whether you guys have experience with that, given the different legal status in Canada. So, as most of you will be aware, there's 2 active ingredients or at least 2 that we focus on. They come from the cannabis plant. So THC, tetrahydrocannabinol, and CBD, cannabidiol, with the former being psychoactive and the latter not psychoactive. There's actually a whole range of all sorts of other chemicals in there, other types of cannabinoids, terpenes, other things that may have some physiological effects, but are much less well described. CBD, or cannabidiol, is effective for some types of epilepsy. And there are randomized studies that show modest benefits for nausea, insomnia, pain, and anxiety. Now, these cannabinoids, or cannabinoids in general, are primarily hepatically metabolized. They're highly lipophilic, protein bound. So there doesn't seem to be much impact of kidney function on their metabolism. And although I don't know anyone's published on it, we don't expect that they're dialysable. And I understand in Canada, cannabis is legal. In Australia, we have a medicinal cannabis program where patients are able to access it, but the doctor has to be an authorised prescriber. It's quite easy to become an authorised prescriber, but many doctors, well, I think, well, I should say, obviously, most doctors are not authorised prescribers, and so the access is still quite limited, I think. People need to be quite motivated to go out and get it. So, I mean, why cannabinoids? Well, cannabinoid receptors are widespread in the body. There's CB1 and CB2, and they're found in the central nervous system, the immune system, the kidneys themselves, the gastrointestinal tract, and we'll talk a little bit about the peripheral nervous system as well. And so, there's reason to think that modulation of the cannabinoid system, or the endocannabinoid system in the brain, might impact restless legs. They seem to have a role in insomnia, so circadian rhythm might play into that. Nausea, anorexia. I mean, there's the classic munchies that people sort of talk about, that so maybe we can improve our patient's appetite. And I'll also mention particularly cannabidiol actually doesn't do a lot at cannabinoid receptors, but has action at quite a lot of other receptors that may be of interest to us. So in particular, TRPV1, which is a channel on peripheral nerves, in particular on pain fibers and itch fibers, and it's where capsaicin acts. And so, that the theoretical potential there for cannabidiol to have an impact on uremic pruritus. It also affects serotonin and GABA signaling as well. So there are a few small studies looking prospectively at cannabinoids in our kidney failure population. The earliest one I know of is this randomised crossover study from an Israeli group, where they randomised, I think it was 15 participants, hemodialysis patients with chronic pain, to either a placebo oil or one of 2 types of a cannabis oil. And the cannabis oils had the same ratio of THC and CBD. And it's quite common that medicinal cannabinoid oils will have a ratio of both THC and CBD, with the idea that the CBD might offset the psychoactive properties of the THC. But this group used whole plant extracts and some other pure cannabinoid extract, which kind of goes back to the issue that I think it's important to keep in the back of your mind, that just straight cannabis oil is going to have a lot of stuff in it, and that whole plant extract is going to have hundreds of different chemicals, whereas you can get more purified products that have a specific amounts of CBD and THC that you might be interested in. So this group randomized into 3 arms. They crossed over, and didn't see any effect. I mean, it's a pilot study, but no difference in pain. I mean, unfortunately, not even a hint of benefit. And one poor patient accidentally took a bit too much THC and had hallucinations. So again, underlining the caution that we need to apply, particularly in our older patients. I mean, because there's definitely evidence from other areas of medicine that older patients are more susceptible to adverse effects from cannabinoids. So the next randomized study that's been published is from David Collister, who I'm sure many of you know now in Alberta, and David's got an interest in CBD, and we're working together on grants. But he's dropped this at ASN last year. His Disco Pot study, fantastic name. And so he was aiming to improve uremic pruritus, and he chose nabilone, which is a synthetic THC, and patients were exposed to 0.5 milligrams BD or placebo and crossed over after 4 weeks with a 2-week washout. Only 14 patients, but he still sort of felt that with the randomized crossover design, he'd have power to detect a clinically meaningful difference in itch if one existed. Unfortunately, that was not found. He did seem to find that the nabilone was quite well tolerated, but no apparent benefit in itch. I wonder whether that comes back to the fact that the THC is not known to act on TRPV1, whereas CBD might have an effect in this space. Again, we don't know. And then finally, my own small contribution to this space. So we've recruited a bunch of patients to a small phase 1B study of cannabidiol alone in people with kidney failure. We set out to obviously look at the safety and tolerability of this drug. Really, the aim's now to go on to larger studies, having an understanding of what sort of doses we might like to use. So I recruited from my own site adults with kidney failure, and we did include some patients with conservatively managed kidney failure on the CKM pathway. We excluded those with a transplant or on a transplant wait list, and that just highlights, I suppose, a practice point if people are prescribing these or have patients using them, is that both CBD and THC will interact with tacrolimus. They interact with a number of things via the P450 enzyme system. And I obviously didn't want to annoy my transplant colleagues by having a patient turn up on a drug that lasts 3-4 weeks in the system and might make tacrolimus dosing it less predictable. We recruited patients with a high symptom burden or used ESAS and had access to a sublingual wafer that dissolved under the tongue and delivered CBD without THC. All patients continued to receive kidney supportive care via our kidney supportive care clinic. So a lot of these CBD and THC studies start with the dose titration period, as did mine, over 2 weeks, followed by a 4-week, what was meant to be stable dosing, and it followed patients up again 4 weeks after that. I recruited 12 individuals, ranging in age from 50 to 85, mostly males of European origin or North African origin, with obviously the usual range of causes for kidney failure. Most were on hemodialysis. We had a couple on PD and a couple of conservatively CKM patients. 4 patients agreed to do a pharmacokinetic study, so they'd come back in the morning and stay all day for a dose of CBD and some blood samples. And the patients were highly symptomatic, as we expect and consistent with the data at the start of this talk. Poor sleep and fatigue were top of the list. Of the 12, 7 finished the 6 weeks still on the CBD. 2 had mild adverse effects, nausea, and one guy found trouble sleeping. And 2 just stopped taking it because they thought it wasn't doing anything. And one unfortunately passed away from his kidney failure with very low baseline function. There were 8 adverse events that were judged by the independent adjudicator as related to the CBD, and they were all quite mild. And of the 12 patients, 4 wanted to continue CBD, despite the fact that it's reasonably expensive in Australia. And I did note that a couple had some asymptomatic small rises in GGT, and there is a known association with hepatotoxicity. Again, sort of potential practice point if your patients are exposed to this, just to keep an eye on their LFTs. My patients did a whole lot of different things. Their idea was to titrate up to a level that they found some symptom relief without adverse effects, and then continue with that. We had a number of patients who just continued to want to up titrate their dose. The guy down in the bottom right gets his own y-axis because he was quite comfortable experimenting with high doses. And I mean, I think from a learning point of view, from me, it was quite useful too, just to see that he quite happily tolerated 1.3 grams of CBD per day, but I mean, with no adverse effects and no benefit either, interestingly. I mean, people do talk about these drugs being highly variable with individual differences in both metabolism and response. I saw improvement in total symptom burden. Of course, we can't make any claims to efficacy here. There's probably mostly placebo and regression to the mean, but pleasing to see nonetheless. And we did see that once the CBD stopped, there was some reversion back towards the baseline. In terms of which symptoms seem to respond, seemed to improve most. Sleep, anxiety, and restless legs led the way, followed by anorexia and pain. So my own interest then would be to look at some of these top 3 symptoms as potential targets for randomised trials. I'll skip over that. Everybody said they felt at least the same or better, which was nice to say that to my face. No difference in quality of life. The pharmacokinetic data from our 4 patients was rather messy, and I suppose the most we could say is that when compared to there's previous data from a group led by Teo et al., who looked at CBD and THC pharmacokinetics after a single dose across a range of levels of kidney function down to CKD4. And if we look at their CKD4 cohort, there's no obvious difference with what we saw in our study. And that's sort of consistent with what we would expect. And Teo et al. Study suggests that there's no impact of kidney function, no substantial impact on the metabolism of these drugs. In terms of steady state pharmacokinetics, which hasn't been looked at in this population at all before, really wide range. So, we've got levels all over the place, although partly that's consistent with people taking different doses, but I think also speaks to the fact that the absorption of these drugs is dependent on what's in your stomach at the time, and also just a lot of individual variation. I was able to compare it to some modeling that another group had done. They'd sort of generated a hypothetical cohort of healthy people and modeled what steady state CBD levels would look like at various doses. And to a first approximation, the sort of levels we see are more or less consistent with that. Got some interesting feedback. So some patients loved it. CBD was great. Life was great. My symptoms, there's one guy who had a very strong response to restless leg syndrome. Even reasonably low dose, he felt a lot better. Itch improved in some patients. But again, he had some who were just very much, it didn't do anything. To be honest, it did nothing. Just made him feel a bit nauseous. It was one of my own patients who was kind enough to go in the study for me. So just to wrap up everything we've talked about, I think we're going to get a lot of interesting data on routine symptom monitoring, and hopefully that can help us make sure that we're performing that efficiently and effectively. There's a lot of variation in how we manage symptoms, speaking to that need for more evidence. HDF may modestly improve symptoms. CBT doesn't seem effective for insomnia, but certainly may have a role for people with chronic pain. Look, at this stage, I don't think there's any evidence to support the routine use of cannabinoids for symptom management, but I feel it's something that's worth exploring, particularly because I think patients are interested and maybe experimenting already themselves. But the bottom line is that, as always, we need more studies. So I'll leave it at that.
Thank you. That was a really nice overview. I really liked how you explained your interesting graphs and broke that data down for us. I've scribbled a bunch of questions, but I'll open it up to others. Please raise your hand and I can call upon you to unmute yourself. But while you're doing that, so one of the things you mentioned in the beginning is that transplant patients have a lower symptom burden. And again, I don't know if you've looked into this in detail. Is that taking into account the GFR? Like, do we know that transplant patients at the same level of GFR as compared to non-transplant with CKD have a lower symptom burden? And A and B, does that apply to different diagnoses within CKD? Like, do patients with, say, diabetic nephropathy have worse symptoms than those with IgA nephropathy?
So I can speak a little bit to that, but then I don't know the literature in enough detail to answer all of it. I mean, I know that, I think even patients with very good graft function often have a residual burden of symptoms. I mean, some things like itch, goes away, but a lot of not a lot, but the residual symptom burden, like difficulty sleeping, anxiety, sometimes chronic pain, which probably, as I think we can all expect, relates to a history of chronic illness much more than just kidney function itself. To your sort of latter point about the symptom burden depending on cause of kidney disease, I think that's off the top of my head. I'm not aware of studies, but I think we'd all expect that your diabetic patients are going to be more symptomatic given the comorbid impact of diabetes as compared to your IgAs, who are often pretty well otherwise.
Thank you. That does make sense. So the conference room, please.
Thanks, Bob. It's Mark here. Thanks very much, Dr. Smyth. It was a really enjoyable talk. One of the things that I noticed in the CONVINCE trial, which obviously was powered for mortality endpoint, whereas a lot of the quality of life related interventions would have a much shorter timeline of 3 months or 6 months, or maybe out to 12 months. And so most of the scores between the two, the intervention and comparators, seem to diverge after about 18 months, which, if they had restricted the analysis obviously to a shorter timeline, it wouldn't have been observed. So I'm wondering, like, how much of that is potentially due to an artifact from a survival advantage, or is there a plausible mechanism by which HDF would just take that long to improve an individual's symptoms?
So my understanding of to speak to CONVINCE, I think my understanding of the methodology they used in that quality of life study, where they were doing those omnibus tests, it wasn't actually on the linear mixed models that I showed you with all the data points over time. They did the omnibus test on the difference from baseline to 30 months or 36 months. And so that meant that they only included survivors. So that speaks to your point about just a survival advantage is going to improve quality of life, it favor the people who are surviving. So they've at least made some effort to avoid that source of bias. Then I suppose the data from CONVINCE doesn't give us a lot of information about the mechanism whereby you might be seeing improvement in quality of life. And I suppose the word, I use improvement there, the word should probably be, just less deterioration perhaps across these symptoms. And I know there's been, like my PhD supervisor performed a smaller study looking at HDF and neuropathy with a view to thinking that perhaps neuropathy would improve with HDF. And despite the study ran for a couple, I can't remember, it was at least a couple of years of follow-up, that didn't show an improvement in neuropathy. So I suppose we don't know how HDF is improving symptoms, and many of these symptoms are very multifactorial. So if you're minimizing cardiovascular burden and cardiovascular events and so on, all that stuff's going to feed through to symptoms. And again, I suppose to your final point about big studies, you're able to detect smaller differences, and the differences that the convinced study showed were reasonably small.
Great, thank you.
Yeah. So again, to not to belabor that point, but somewhat to do that, that convince was like, more than 1,000 patients. Now, even David Collister studies have been, 10, 15 patients, and so is yours. Do you think that might be playing a role here? Again, we have done, maybe we are looking for too large an effect size with CBD. Maybe we need a large study, or maybe maybe that small effect size doesn't matter. So what you're shown is that there is no large effect. How should we think about
that? Yeah, good question. So firstly, I guess and I guess what you're getting at is the difference between HDF. You're not really doing HDF for the symptom benefit. You're doing it to live longer, and so. And also the fact that HDF doesn't really place any additional burden on patients. Whereas a small improvement in some random anxiety score is great, and we're happy to wait 30 months to see it because we're getting other benefits without any other cost, really. Obviously, CBD or drug therapies are very different. And I think we absolutely need larger studies that are powered to look for clinically important differences. And David and I have sort of debated whether to go parallel group studies, which do need to be bigger, or his approach that he started with, which is the crossover design. I mean, there is pros and cons to both. I mean, I think the long half-lives of these drugs is only one thing that makes me favor the parallel group design, and my preference would be for a larger study where you've got a good power, 90% power to get a meaningful clinically important difference. Also, too, because particularly at this stage with cannabinoids, having bigger data sets also allows you to look for a lot of other questions about what they might be doing, both in terms of adverse effects, but also potential actions on other symptoms that may not be your primary target.
Yeah, that does make sense. That does answer my question. But to again go back to the CBD, we faced actually similar issues as you did when we had a brief period, maybe a few years, when physicians could prescribe, and there was a lot of reluctance. I did not get a license. I don't know any of my colleagues who did, though it wasn't that difficult. But now it's legal, right? We have stores on every corner where you can buy CBD, and it's sort of out there.
Are your patients using it?
I am not tracking it, but I do know. Again, I don't ask. I don't know if others do ask, but it's pretty easily available. You don't need to, you don't need a prescription, and people are using it right, left, and center, perhaps. Maybe we should. So doing a placebo control trial might be a little bit tricky because some people might be using it and then have to go off it. But let's get to other people's questions. Peter?
The issue of should one use cannabis or one of the specific components of cannabis. And I think a lot of times the trials or the discussion is sort of more political than making a choice of what you might think works best. David did his trial because it's something that's already licensed for medical use in Canada. And you can't really send somebody to the corner store for your trial drug. Most people who ask me are old people who always ask about CBD because I think in old people's chat groups, that's what get talked about. I always wonder, like, what do they have against cannabis? What do they have against getting high? Maybe they're older than me and didn't get high when they were teenagers, but you showed that chart of all the multiple things that cannabinoids might do. So is there a problem with just choosing the wrong cannabinoid, and should we all just be using full-on cannabis with everything in it? Well, or not just THC, but with all the terpenes and all the other stuff.
So I think, there's a couple of ways to answer that, and there's validity in it. So I think for patients who are familiar with cannabis and, you know, look, who are frankly interested and want to use it, particularly for your conservatively managed or dialysis patients who are older, I absolutely have no problem with patients self-initiating and seeing how it goes. I think the data does suggest some caution in older people, and you know, you might want to say, look, you might have enjoyed this, you know, in your youth, but you are older now, so take it easy. That people may be more susceptible to the psychoactive effects and side effects. But so yeah, broadly, I mean, if people want to use something like that, then that's fine. The two things I'd follow up with is that in terms of long-term use, there's a little bit of data from animal models that suggests potentially an adverse effect on kidney function. That's very early sort of animal model stuff. There's not a lot in it, but enough to make me a bit cautious about, you know, CKD patients who might be using it for many, many years and want to preserve kidney function. That's a theoretical concern, though. The other one really is just about cost. You know, I mean, I don't know how expensive it is there, but access to these drugs is, you know, it's a few $100s a month, which to some of our patients is a lot of money. And so I think we partly owe it to them to generate a bit of evidence so that we can actually say with some confidence whether it does or doesn't provide any benefit.
Yeah, absolutely. Yolanda.
Hi. I guess one of the contexts that we've talked to our patients about cannabinoid use is when we suspect they might have hyperemesis syndrome as the cause of their recurrent nausea and vomiting. I was wondering whether, given the other, you know, known impacts of kidney disease on the GI tract, is that a more common issue for patients with end-stage renal disease or advanced CKD?
So I wish we had the data to answer that. It's not something that's come up in, you know, either what David's told me from his work or that I've seen in publications about CKD patients. And so, yeah, whether they're more prone to that or not, I don't know.
So it didn't come up in the studies that
yeah.
the more common side effect. Yeah, it's how I learned about it. Didn't know it existed before all our patients started complaining.
Yeah.
Oh, really? Yeah, right. Interesting.
Yeah. So to pivot a little bit from the fun CBD discussion, cannabis discussion, one of the things that has come up is, you know, from Rajneesh Mehrotra's study is that you could look at it in different ways. One is that, you know, trazodone is not better than placebo, but the other way to look at it is that placebo is as good as trazodone. So some people have argued, you know, why not, you know, like melatonin is perhaps like a placebo, maybe that's something. Why not give something that is, you know, but trazodone has, you know, adverse effects from that trial. So why not give something that is benign, like a vitamin or melatonin or whatever, and if, or maybe do N of 1 trials, you know, if you try something, if it works, then leave them on, and otherwise try something else. Is that approach something that you could ethically
I think
is okay, or yeah?
To the N of 1 study stuff first, because I think that's easy, because I mean, in practice, that's actually what we do really in symptom management, and it's what I see the palliative care and symptom management experts do is you try one thing and you try something else. Yeah, I suppose a side point there is that what's interesting is perhaps there's synergies between drug combinations for some of these symptoms that we're not really exploring. But you know, maybe you could do that in your N of 1 study, or maybe we do that down the track. To your other point about the placebo effect, I mean, that's obviously a much bigger question. And I think it also too even feeds into the concept of a kidney supportive care clinic. I mean, my own introduction to that was the clinic at my hospital, which is run by a guy called Frank Brennan, who speaks internationally about conservative kidney management. And he has this wonderful, calm, priestly kind of manner that I think he is responsible for most of the effect that the patients get. And that's, you know, that's legitimate. You know, that patient doctor relationship is worth a lot as well. And even if it might be sort of placebo. So giving your patients a placebo, or just allow, I suppose that's back to Peter's point, and you're sort of allowing patients to choose an experiment and find things that work for them, whether that's real or not.
I mean, I
That
always
might be
wonder,
okay.
yeah. So for example, I always wonder about, vitamin E and cramps. There is some, small trials showing some effect,
Yeah.
but whenever I prescribe it, I always hype up the effect, saying this is really
Yeah.
going to work. And I wonder if
Yeah.
that's what works rather than the
Particularly magnesium. I mean, I'm
yeah, magnesium.
Yeah, it's got to be the same.
And I don't think there are any other questions. So thank you again for that wonderful talk. And it's really a vexing issue. So it's good to know that we are, we are facing the similar issues. And thanks to efforts by you, David, and all the others in trying to address this this topic.
Thanks very much for having me, and thanks for the discussion. It's great. See you all later.